This is Sharon back from Brandman University. I'm giving my presentation on patient's perspective of care. This is the story of a patient named Jean. She is 89 years old. She is a retired school teacher. She has been a widow for almost 20 years and has been living on her own for all that time. Her only significant health history is a history of hypothyroidism and mild hypertension, both of which are well managed with medication. Currently, she still drives. She lives alone, as I said before. She does water aerobics 3 times a week, teaches English to Spanish-speaking women, has been on a primarily vegetarian diet for many, many years, so her cholesterol is quite low. She has a Scotch-Irish background. She decided to have a total hip replacement because she desired to stay active and relieve the pain that she had begun experiencing when she walked. When she went to the physician and had x-rays, the x-rays showed that she had bone on bone with her cartilage in her hip, and that without the surgery she would become wheelchair bound in the next year. Following the surgery, Jean was placed on her back with a wedge-shaped brace between her legs. She, of course, also had the bed rails of her hospital bed were up at all times, other than when nurses were there. She refused pain medication with the exception of IV Tylenol. Not uncommon for Scotch-Irish Stoic patients, she didn't really wish to have a lot of pain medication if she could manage her pain on her own. She was also aware that pain medication can dull her mental status, and she was really interested in not having that happen. She had a moderate pain, but it definitely was manageable. She was placed on a bed alarm, which was very loud. When she protested that she was alert and oriented, she was told all patients over 80 had to have it despite their mental status orientation. This particular alarm was very, very sensitive whenever she moved her hips at all. Now remember, this is a lady that could not move onto either side or in any other position. She had to stay on her back for the first 24 hours. And whenever she clenched her buttocks or moved in any way, the alarm went off, which could be heard completely down the hall so the nurses could hear it. She was very frustrated with this alarm, and I was in the room with her at all times. This is my mother. The Endo article that we were asked to read for developing this PowerPoint perspective on patient preferences talks about 5 domains that need to be assessed when we are trying to obtain cultural competency and increased quality of care for patients that we are working with. And I think 2 of these domains are involved in my mother's patient preference story here. One was the shared decision-making and respect for patient preferences. This involves assessing a patient's willingness and ability to be involved in their care, respecting the patient's cultural differences, and allowing the patient to make the final decisions about their treatment if they are oriented and competent, if not involving their medical power of attorney if they have one. The other domain that I believe was involved in Jean's care involves experiences of discrimination. Discrimination involves disparities in decisions about health care based on perceived characteristics of a group. Now, this could be a racial group, it could be a patient's ethnicity, or it could be another factor such as age of a patient. Ageism is alive and well in healthcare. I believe that there were several contributors to this particular problem being difficult for the patient to manage and for the staff to resolve. The first of all was the patient and family contributions to the problem. The patient here was not feeling good. She had been up, pretty much all day after surgery. She was exhausted, she was passive, and she was really afraid to ask for her needs to be met. The family who were with her, which was myself, basically waited too long to speak up, and I believe for me this had to do with being in my own hospital where I felt like there was some pressure on me to be a good personnel, a good patient, and just tolerate whatever came along for my mom, but I finally did speak up. The medical team contributions here involved the nurse being fearful of not following a new protocol. These bed alarms were brand new. I believe this was the first time this particular nurse had ever used one of these. It was way too sensitively set so that it literally went off about every 30 minutes all night. And I think she had not had any time, because she came in on the night shift, to really have any kind of an assessment if my mom was safe by her, without the bed alarm. It was kind of an interesting overkill situation on the nurse's part, because my mother had both this wedge-shaped barrier between her legs, and she had both bed rails up, and she had the bed alarm, and I was sitting by her bedside. So interesting. An outside contributor, of course, to the situation was inadvertently the Joint Commission safety initiatives, which are being very tightly followed in my hospital, which in general is a good thing, so that people don't fall, have a decreased risk of falling. The solution to Jean's problem would have been, most likely, a more individualized approach to her care. I believe that care is expected to be, as we've pointed out through the domains, non-discriminatory in nature, and making a decision that anyone, no matter what their condition, needs to have a bed alarm over age 80 is a discriminatory policy as far as I can ascertain. I believe that excellent care is sensitive to their patient and their own individual needs. I am sure that the nurse that was caring for my mother, for Jean, did not have time that night or probably did not feel she had time to have to make an individual assessment of her mental status. The truth of the matter was, though, by not doing so, she was in that room every 20 minutes from midnight until 5 o'clock trying to reposition this bed alarm that she was expected to keep on my mother. Finally, at 5 a.m., I just told her that as my mother's medical power of attorney, I was refusing this intervention. That did result in the bed alarm being discontinued, and when the day shift came on and they were able to make a full assessment of my mother's mental status, they agreed that there was no reason for her to have such an intervention. It certainly is important to allow patients and family to make decisions, or at least to have a good amount of input into decisions about care delivery. This is difficult when patients are uneducated about medical care and what needs to happen for people to recover. It is also important to assess how much education, where are they in terms of medical literacy, when we are trying to ascertain how to make decisions about care delivery and who has the right to have input and how much input they need to have. So I really think the answer is more individualized care. Jean is now 8 months post-surgery. She's back to driving, going to the health club, enjoying friends and family. She is also pain-free. The orthopedic surgeon that did her surgery reports she has grown more bone than most people that are half her age, due to her many health-promoting behaviors earlier in life and her good genetic status. I think that Jean has more years of enjoyable and now healthy, active life ahead.